Uh, in this session of the oral pathology, I'm going to cover some of the important topics which I am expecting definitely for the upcoming NEET examination. So in this session, we are not going to discuss any MCQs. So in this session, we are not going to discuss any MCQs. We are going to discuss only the important salient topics. So here, I request you to give full attention and if possible, write down the notes, some important notes, points, which are definitely going to be helpful for the upcoming examination. Okay, these are very classical, you can say the most high yielding topics. Now let us start with the first topic here, that is cleft lip and cleft palate. Here in this table, if I zoom little, you can see here what this chart says is that cleft lip, cleft palate is 70% of the times non-syndromic. So usually syndromic cases are very less. So here percentage doesn't matter. Don't worry. Some books give it as different percentage. So here just remember non-syndromic cleft lip, cleft palate are more common than syndromic. Okay. Then coming to the second part, if you see the side of involvement, whether it is unilateral cleft lip, cleft palate or bilateral, most of the times it is unilateral. 90% of the cases it is unilateral cleft lip and cleft palate. So again a question comes here, if it is unilateral, which is the side which is most commonly affected, whether it is a left side or the right side? Left side is the most commonly affected, that is around 66% of the cases. So most of the cases of cleft lip and cleft palate are unilateral. That too, 66% of the cases are involve the left side of the face, or you can say the left side of the palate, left part of the lip. Okay, so here we have to understand that most important here is cleft lip, cleft palate, most of the cases are non-syndromic cases. And if you see the site of involvement, left side is the most common site. Okay, now after this, coming to some genetic aspect of cleft. So here this is again a very classical question, genetic aspect of cleft. Again, this can be one of the potential topic for asking in the to appear in the NEET exam. What are the various genes? Here I just want you to remember two important genes. One is IRF6. What is IRF6? IRF6 stands for interferon regulatory factor 6. IRF6. This is considered to be the most important and consistent gene. Remember, this is the most important and consistent gene whose mutation causes cleft. So whenever cleft patient is there, this is one of the consistently this gene is mutated always, IRF6. There is one more gene here called as MSX1. What is MSX1? Muscle segment homeobox 1, MSX1. So this is a very important gene, all of us know, that which is involved in the development of the teeth and the paraoral structures. This MSX1 gene mutation is also involved in oligodontia. So we should remember which is a gene which is involved in both cleft as well as oligodontia is MSX1. Now which is the most consistent gene which is mutated in cleft is IRF6. Now there are other genes also. Now one of the gene is transforming growth factor alpha. That is not that important, just need to remember. So two important, one is IRF6 and MSX1. The other genes are TGF, transforming growth factor alpha, bone morphogenetic protein 4, BMP4, PAX7. Please concentrate on the number here, PAX7. Why I'm telling you PAX7? What does PAX stands for? Paired box protein. PAX7 mutation can cause cleft. Remember, PAX9 mutation is associated in oligodontia. Oligodontia, I'm sorry. There's a small spelling mistake here. Oligodontia. So PAX7 mutation can cause the cleft lip, cleft palate. One more is RUNX2. What is RUNX2? RUNX2 is again runt related transcription growth factor. It's called as a RUNX2. So this is a gene which also causes cleidocranial dysplasia. So which is a gene which is associated with cleidocranial dysplasia and cleft? Your answer should be RUNX2. Which is a gene which can cause the both cleft as well as oligodontia? Your answer should be MSX1. Which is a gene which can cause both cleft as well as ectodermal dysplasia? That is PVRL1. PVRL1. This is a very important gene, PVRL1. What is this gene meant for? Sorry. This is a gene which is also known as nectin-1. It is also known as nectin-1 or CD11, CD111. So this can cause both cleft as well as ectodermal dysplasia. So this is the importance. You should remember this can be in this table of genes. This can be a very potential question which can cause, and this has appeared. This PVRL1 has appeared also. This is what it has previously also appeared in one of the examination, that what is the gene which can cause both ectodermal dysplasia as well as cleft. That is PVRL1. Okay, so we should be aware of these genes. Now let us move on to the next part here. That is, what is globodontia? Again, this is a very this term itself is very unique. Okay, that is why I'm expecting this question here. Globodontia. What is globe? Globe. How is globe? Globe is smooth, right? So similarly, if a tooth has got a rounded, it is a rounded totally. I'm sorry. It lacks sharp cuspal ridges, no cusp tip. That means the tooth is totally rounded. Such teeth you call it as globodontia. That teeth you call it as globodontia. Okay, so this globodontia patients will also have hearing loss. These globodontia patients will also have hearing loss. That is why this is also known as otodental syndrome. Globodontia is also known as otodental. Oto means hearing loss, and dental, what is dental here is globodontia. Globe, like smooth. The teeth will not have any sharp cuspal ridges, cusp tips. Okay, it will be rounded. I'll show you an image of that. That is nothing but your globodontia. Now this is the globodontia, where you can see here, usually this affects the posterior teeth. This usually affects the posterior teeth. You can see here. So they don't have any sharp cuspal ridges. Cusps are there, but there is no sharp here. They will be rounded, smooth. That is what is your globodontia. So globodontia can be again a classical image based question which we can expect in the upcoming examination. Okay. Now let us move on to the next diagram here. This is a very simple diagram, but I just want to emphasize the difference between gemination, twinning, fusion, and concrescence. All of us know this is a very important difference, that gemination, where a single tooth is there, that will try to divide into two, attempt. Okay, whereas twinning, if this attempt becomes complete, second diagram you can see. So gemination, you can see just a dip. You can see here gemination, there is just a dip here in gemination, whereas in twinning it has become two here, two teeth completely separated. Fusion means where there is union only at the level of dentine. So this is a fusion. Whereas concrescence, where you will have the union at the level of cement. So this is just a revision to what exactly is gemination, twinning, fusion, and concrescence. Now here I want you to remember two important syndromes associated with supernumerary teeth. All of us know supernumerary teeth, right? Extra teeth. So here there was a question, and we can expect a question like, one is cleidocranial dysplasia. All of us know cleidocranial dysplasia is associated with the supernumerary teeth. And one more important syndrome is the Gardner syndrome or FAP syndrome. What is FAP is? Familial adenomatous polyposis syndrome. Familial adenomatous polyposis syndrome, FAP syndrome, which is also known as Gardner syndrome. So now it has been called as the same Gardner syndrome. So difference here is Gardner syndrome, they say that it has got oral manifestations. FAP doesn't have oral manifestations. So just remember, for the exam point of view, these are the two syndromes which are associated with the supernumerary teeth. Now this is another important topic where we can expect Taurodontism classification, and this classification has given by a person called as Shaw. So please remember the name of the person, Shaw's classification. So if you see this, Shaw has classified the Taurodontism as normal teeth, then hypotaurodont, mesotaurodont, hypertaurodont. If you can carefully see here, exactly this is the furcation area. If this furcation area is shifting downwards, that becomes hypertaurodont. If it is cervically present more, then it is hypotaurodont. So basically difference between hypo, meso and hypertaurodontism is where is your furcation area. The furcation area of the tooth, if it is more apically shifted, that is called as most severe form of taurodontism. That is also known as hypertaurodont. Okay, this is what is your Shaw's classification. Now here some books also give the definition given by Whitcop, which also we should be aware of. This can be again a potential question. Whitcop has defined taurodontism. He has given a criteria for diagnosing taurodontism. According to Whitcop, the root bifurcation is displaced apically. Displaced apically. Okay, so that is very important. See, in the definition, nobody will ask you to write the definition. What we should remember, who gave this definition? Taurodontism definition, taurodontism criteria was given by the person, the Whitcop. But who classified? Classification was given by Shaw. That is what is important. Shaw's classification. Now, O'Haller's classification. All of us know O'Haller has classified dens in dente. We know dens in dente also called as dens invaginatus. Basically, O'Haller has classified this dens in dente into three types: type 1, type 2, type 3. You can see here carefully what is type 1. Only if the crown is involved. So the invagination involves only the crown. Okay. If you see, the invagination is involving even the root also, but it has got no communication with the apical foramen. It may or may not involve dental pulp. It may or may not involve dental pulp. So if it is only the invagination is only in the crown, you call it as type 1. If it involves even the root, it is type 2. Whereas type 3 involves apical foramen. So type 3 is the one where PDL is involved. That is, the invagination involves PDL also through the apical foramen. So that is called as the O'Haller's classification of dens in dentums. Excuse me, sorry. Now, this is an important image of histopathology of the oral submucous fibrosis. I'm sorry. Oral submucous fibrosis, all of us know, is a potentially malignant disorder, which is also known as Indian's disease. All of us know it's also known as Indian's disease. This OSMF, classically we should be able to identify the atrophic epithelium. The epithelium that is there, which is atrophic and hyalinization. Remember, the hyalinization is subepithelial. What do you mean by that? The hyalinization is present just below the epithelium. The hyalinization is present just below the epithelium. So this hyalinization can be mild, can be moderate, can be severe. More is the hyalinization, more severe is the oral submucous fibrosis. So hyalinization, if I say mild grade of OSMF will be less. Severe grade of OSMF, hyalinization will be more. Okay, what is hyalinization? The collagen becoming dense is called as hyalinization. So this can be a very potential image. We should be aware that about the histopathology of oral submucous fibrosis. How to identify? You have to identify the atrophic epithelium. You have to see the subepithelial hyalinization of the connective tissue. Okay, moving on to the important thing in the pathogenesis of OSMF is, at the end, what we should remember here is, due to aracanet, collagen production increases, collagen degradation reduces, and this collagen, basically we know that there is an important enzyme here whose expression increases in OSMF, that is lysyl oxidase. Lysyl oxidase expression increases in the OSMF. What this lysyl oxidase will do? It will cause cross-linking of the collagen. So which enzyme is down-regulated? We can say regulation or expression. Down-regulation of collagenase enzyme takes place in OSMF. What this means that? This means that collagen breakdown basically doesn't take place. Collagen only production is happening. There is no breakdown at all. So because of this, we will not be able to see the breakdown of the collagen, only the deposition of the collagen. That results in oral submucous fibrosis. So you should be aware of these two enzymes. Upregulation of which enzyme? Lysyl oxidase. Downregulation of which enzyme? Collagenase. Now this is an image to show about the oral epithelial dysplasia. So I have shown some of the important characteristic images here. Okay, text part is also there, images are also there, which I'm expecting in the upcoming exam. So this is an image of oral epithelial dysplasia. Now what do you have to see here? You can see that in the epithelium you are seeing so much of changes. The epithelial cells are dark, they are different shapes, nucleus is dark. Okay, all those are called as dysplastic features. So let us see what are these dysplastic features here. Yes, so we can see these cellular features, we can see architectural features. Now what are cellular features? Abnormal variation in nuclear size, anisonucleosis. Abnormal variation in cell size, anisocytosis. Increased nucleocytoplasmic ratio. Increased nuclear cytoplasmic ratio. Enlarged nucleus. Hyperchromatic nuclei. Abnormal mitotic figures. Pleomorphism. All these we have discussed in the class. So we should be aware of what are the cellular changes, what are the architectural changes. Architectural changes means there will be loss of polarity, there will be increased basal cell hyperplasia, there will be dyskeratosis, there will be bulbous retenages. All this list is already we have discussed, but this can be a potential MCQ. Which all of the following are the architectural changes in oral epithelial dysplasia except. So they'll give three options which are architectural changes. One will be a cytological change. Vice versa they can ask. Cytological change there will be 3 and 1 will be architecture. So we should be aware what are the various cytological features, what are the various architectural changes for the oral epithelial dysplasia. Now moving on to the intramucosal nevi. Now this is an image of all of us know nevi. What is intramucosal nevi? If the nevi is present, nevus cells are present in the connective tissue completely, you call it as intramucosal nevi. That means it is not involving the epithelium. Epithelium part is not involved. Only the connective tissue part you are seeing the nevus cells, that you call it as the intramucosal nevi. Whereas the junctional nevi is the one where you can see the nevus cells at the junction. Carefully see this diagram. I'll just zoom for you. You can see here the nevus cells are exactly at the junction of the here epithelium and connective. You don't see in the connective tissue. That is why we are going to call this as junctional nevi. Junctional nevi. So, now let us move on to the next image here, that is compound nevi. We can see here carefully, beautifully. You can see the nevus cells in the epithelium also and also in the connective tissue. This you call it as compound. Compound means if the nevus cells are present in two places, we are going to call it as compound nevi. But remember, some students get confused between nevi and melanoma. Melanoma cells also look like this. Melanoma is malignancy. Nevi is hamartoma. We have to differentiate that this is nevi, this is melanoma. How to differentiate? Look at the cells. The cells here in nevi are very innocent. They are not hyperplastic. They are not hyperchromatic. They are not dysplastic. They don't exhibit any atypical features. Whereas look at this image. Next I will show you. This is a melanoma. Look at this. How are these cells? These are very atypical melanoma cells. They are very dark cells. They are very hyperchromatic cells. They have different shapes. They also have melanin. Nevi also has nevus cells also will have melanin here. But remember the difference, that atypical features are seen in melanoma, whereas they are absent in case of the nevi. They are absent in case of the nevi. Okay, now this is an image of giant cell lesion. Now what exactly is a giant cell lesion? It's a big group of lesions where you will see histologically giant cells. Now this giant cells, I have made a table for you people. Okay, this is from one of the article. You have to, this table can be useful for you, but remember, I'll tell you what you have to remember here. This entire table need not to be remembered. Some important points. What are the various giant cell lesions? These are all giant cell lesions. Cherubism is giant cell tumor, aneurysmal bone cyst, CG, all these are giant cell lesions. But what is the important difference here? Important difference here is that cherubism is autosomal dominant. Giant cell tumor is a neoplasm which is destructive. I want you to remember the word neoplasm. That means it is a benign neoplasm. It is not malignant. It is benign neoplasm. But it is very destructive. Aneurysmal bone cyst is a cystic lesion. And CG is a non-neoplastic lesion. It is a reactive lesion. Actually, CG is a reactive lesion. So we should know the basic differences between these four nature, which is a benign neoplasm, which is an autosomal dominant, which is a non-neoplastic. Okay. So another important point to be remembered here is, among all these four, the two will have pain. There will be pain in giant cell tumor. There will be pain in aneurysmal bone cyst. Remember, CG and cherubism, there won't be any pain. They are painless. They are painless. They are painless. Okay. Next important point is the histopathology. Here, I want you to remember that in the histopathology, the eosinophilic cuffing is specific for this lesion. What do you mean by eosinophilic cuffing? Is there will be collagen deposition. That is called as eosinophilic cuffing. Please remember, this is very characteristic of cherubism. Eosinophilic cuffing is very characteristic of cherubism. You are supposed to remember this. Now, what about giant cell tumor? Giant cell tumor will have multiple giant cells and there will be numerous nuclei in each giant cells, 40 to 60 nuclei, and there will be mitotic figures. That itself is telling that it is an aggressive benign neoplasm. We have seen dysplastic features, right? Abnormal mitotic figures. So only in dysplastic lesion, in atypical lesion, I'm sorry, you will see this mitotic figures. So giant cell tumor will have these mitotic figures. What about aneurysmal bone cyst? Aneurysmal bone cyst will have sinusoidal spaces. It will not have any blood vessels. It will have sinusoidal spaces without endothelial lining. There won't be any endothelial lining in aneurysmal bone cyst. Whereas in CGCG, the giant cells are very small, number of nuclei are also very small, and they are scattered. They won't be located in one place. In CGCG, throughout the stroma, you will see giant cells in CGCG. And the nucleus will be small, number of nuclei will be less, cells are also small. In giant cell tumor, it won't be like that. Nuclei are larger, giant cells are larger, and they are not scattered, they are localized. Wherever you see blood vessels, around those blood vessels, you will see these giant cells. Okay, so that is the importance of this table. This can be a very potential table. You can expect an MCQ from this table. Now let us move on to one of the important recent concept which we should be aware, that CGCG, there is a treatment which is denosumab. What is this exactly? This denosumab is, it is a rankle inhibitor. We know that denosumab will basically act against the osteoclasts. So what is happening in CGCG is osteoclasts are activated. So if you use denosumab, this will definitely reduce the osteoclastic activity, and because basically this is a rankle inhibitor, so it will reduce the osteoclastic activity, hence bone resorption reduces. So CGCG or GCT, you can use this denosumab. This can be a potential MCQ. Please remember this name of the drug, denosumab, which is a rankle inhibitor. This is a rankle inhibitor. Now coming to the treatment of Kaposi sarcoma. Again, this is a very potential question. Kaposi sarcoma, all of us know, this is a soft tissue malignancy or soft tissue sarcoma, which usually is seen in AIDS patients, HIV positive patients. In these patients, usually they will give liposomal doxorubicin. Doxorubicin is the first line of treatment for Kaposi sarcoma. First line of treatment for Kaposi sarcoma is doxorubicin. You also give highly active antiretroviral treatment, basically in Kaposi sarcoma, to prevent the spread. The Kaposi sarcoma should not spread, so we give basically heart treatment is given. Kaposi sarcoma, this is again a very classical question, that which part of the oral cavity it affects. Usually it affects hard palate. 50% of the cases affects hard palate. 28% cases involve gingiva. 28% cases involve gingiva. So please remember the name of the drug, doxorubicin, and the most common sites for Kaposi sarcoma. Moving on to the next topic here, about the histopathology of pleomorphic adenoma. All of us know pleomorphic adenoma is the most common, you can say, the salivary gland neoplasm. It is a benign neoplasm, most common salivary gland neoplasm. It is also known as a mixed tumor, benign mixed tumor. Histopathology of this pleomorphic adenoma is very important. What do you see in this? We can see these cells, these things. What are these? These are cyst-like spaces. These are cyst-like spaces. So we can see some cyst-like spaces, which you can see that they are filled with some eosinophilic material. That is called as eosinophilic coagulum. Eosinophilic coagulum. You can see here hyalinization, the pink area that we have seen in OSMF. Same we can see here also in pleomorphic adenoma. So in pleomorphic adenoma, you can see these classical cyst-like spaces, and these cyst-like spaces will be surrounded by cells like this. These cells are nothing but your myoepithelial cells. What are these cells? These cells are I'm sorry, myoepithelial cells. So myoepithelial cells are surrounding these cyst-like spaces in pleomorphic adenoma. This is a classical image that we are supposed to remember. This can be again a potential MCQ. This is just a schematic way to tell how the pleomorphic adenoma looks histologically. You can see here the chondromyxoid stroma. They call it as chondromyxoid stroma. Please remember this name. Where you see chondromyxoid stroma, in case of which salivary gland tumor, means it is the pleomorphic adenoma. So pleomorphic adenoma will show chondromyxoid stroma. This can be a potential MCQ. Okay, so that's about the pleomorphic adenoma. Let us move on to next, mucoepidermoid carcinoma. Now mucoepidermoid carcinoma, all of us know that's the most common malignancy of salivary glands. Okay, it is usually it's the most common malignancy in adults also, salivary gland malignancy in adults also, salivary gland malignancy in children also. This mucoepidermoid carcinoma has been actually graded. So this mucoepidermoid carcinoma has been graded by one of the important institute here called as AFIP, Armed Forces Institute of Pathology. They told that you have to see these things. Cyst, how much part is there? Perineural invasion, how much is a necrosis? How many mitosis are there? What about the anaplasia? Okay, what about the bone invasion? What about the blood invasion, blood vessel invasion? You do not remember these things. Don't worry. What question you can expect here is, based on these criteria, we can grade mucoepidermoid carcinoma as LG, IG and HG. What is LG? Low grade. What is IG? Intermediate grade. What is HG? Higher grade. Higher grade. So if the score is more than or equal to 7, you call it as high grade mucoepidermoid carcinoma. If the score is 0 to 4, you call it as low grade. If the score is 5 to 6, you call it as intermediate. Okay, so here what we are supposed to remember is, low grade LG will have more of cystic spaces. Cystic spaces will be more. LG will have more of cystic spaces, whereas HG will have literally no cystic spaces. There won't be any cystic spaces in HG. Okay, so this is a very important point you have to remember in the mucoepidermoid carcinoma. Now let us move on to the next here, histopathology. I'll just show you an image of histopathology of mucoepidermoid carcinoma. You can see this are the mucous cells. So this image they won't show. Don't worry, this image they won't show. You can expect this image where you can see two cells. See, mucoepidermoid carcinoma. Mucous cells, epidermoid cells. Now the cells which I have highlighted in the center are the mucous cells. And all the dark cells which are there, they are epidermoid cells. So mucous cells, epidermoid cells. Center you have mucous cells, all other surrounding you have epidermoid cells. Here one more point I want you to remember. In LG, low grade, you will see more mucous cells. Whereas in case of high grade, mucous cells will be less and epidermoid cells will be more in case of high grade. So if you see histologically also, there is a difference between the low grade and high grade. One of the important differences, more the cystic space in the low grade, more mucous cells in low grade, whereas less cystic space in high grade and less mucous cells in case of high grade. Okay, so obviously since mucous cells are less in high grade, of what you will see? More of epidermoid cells. So in high grade, you will see more epidermoid cells rather than mucous cells. Okay, this is another image of the histopathology image of adenoid cystic carcinoma, where you classically see the Swiss cheese pattern. Swiss cheese pattern. Again, this is a very classical image. I want you to remember this Swiss cheese pattern, where you will see like this small Swiss cheese. Okay, how it looks. That is exactly what is nothing but the Swiss cheese pattern of the adenoid cystic carcinoma. Now, there is another important classification which we have to be aware of. I don't want you to remember an entire classification. They won't ask you this. Just remember the ACR or ULAR classification. ULAR stands for European Union. So that ACR or ULAR classification has been given by for Sjögren syndrome. For Sjögren syndrome. According to this criteria, the highest score is for the labial salivary gland biopsy. All of us know the most diagnostic criteria for Sjögren syndrome is labial gland biopsy. For the diagnosis of salivary Sjögren syndrome, you have to do a biopsy from the lip and you have to check the foci. How many foci of lymphocytes are there? In 4 mm square area, just make a 4 mm square area. How many foci are there? One foci is 50 lymphocytes. If more than one foci is there, then it is Sjögren syndrome. This is the most characteristic or reliable criteria for diagnosis of the Sjögren syndrome. There are other criteria, other scores. Don't worry about that. They won't ask you all those things. But remember, you can expect this question that the which is the most consistent criteria. Another I think I want you to remember is also that HCV, hepatitis C virus, is associated with Sjögren syndrome. They also say HCV, hepatitis C virus, is frequently associated with the Sjögren syndrome. We should be aware of this also. Other criteria, don't worry, they won't ask you of that. Just remember the most important or consistent criteria. Now, coming to the another important topic, that odontogenic cysts, we know that they will contain fluid. Now, what exactly is the difference between the fluid of these different cysts? Here in this table, which I have taken from a very old textbook, okay, this is from the earlier edition of Marks and Stern, where they have given that in case of the OKC, odontogenic keratocyst, the total protein will be less. It will be less than 5 grams. Whereas in dentigerous cyst, it will be 4 to 8 grams. Whereas in radicular cyst, it will be 5 to 11 grams. So OKC will have a less of total soluble protein. That is the gist. That is what you are supposed to remember also in the exam. OKC or odontogenic keratocyst will have less of a total soluble protein. 4.5 to 5 grams. Some books give it as 4.5. Some books give it as 5 grams. It will be less than that in case of the OKC. Let us move on to the next here. I'm sorry. This is a histopathology of OKC. I want all of you to remember this. Again, a classical image-based MCQ where the arrows, what are those arrows? Those arrows are nothing but para-keratin corrugation. They are nothing but your para-keratin corrugation. So all other you can see classically in OKC that there will be basal cells which exhibit tombstone pattern, tombstone appearance. So those basal cells will be there, those para-keratin corrugation will be there. Okay, in case of classically the odontogenic keratocyst. Now this is another image of COC or Gorlin cyst, which will show presence of ghost cells. These are the whatever highlighted the arrow mark, those are ghost cells. Remember, ghost cells are seen in COC or Gorlin cyst. What is COC? Calcifying odontogenic cyst. So this cyst will show the epithelium. Here you can see down here, this is the epithelium, right? So in this epithelium itself, you are going to see the ghost cells. Within the lining epithelium, we are going to see the ghost cells. So those ghost cells are very characteristic of this particular cyst, that is the COC. You can see ghost cells also in odontomes, ameloblastic fibrodontomes. Okay, wherever odontome comes, you will see ghost cells. Now this is another image. I have taken it from an Instagram actually. I got this image. It was very beautiful image to explain Vickers-Gorlin criteria. So this Vickers-Gorlin criteria, all of us know that it is a criteria for ameloblastoma, ameloblastomatous transformation. So we should be aware of what is Vickers-Gorlin criteria. We should know that the ameloblast cells, they look typically tall columnar cells. Number one criteria. Number two is hyperchromatism and palisading and polarization. All the three are common. Actually, in this they have shifted. You can include it in the one only, that the nuclei are palisading. Palisading means same level. Nuclei are hyperchromatic and they are away from the basement. Third criteria is actually the vacuolization. So this image is very beautiful image which explains you about the Vickers-Gorlin criteria, and Vickers-Gorlin criteria is the criteria for exactly to tell about the histopathology of ameloblastomatous transformation. If a dentigerous cyst has to convert into ameloblastoma, it has to exhibit all these criteria. Those criteria are called as Vickers and Gorlin criteria. Now, this is a follicular ameloblastoma. Obviously, we are going to see this Vickers-Gorlin criteria here. Okay, if I zoom and show, you can see all those Vickers-Gorlin criteria. Tall columnar, these are ameloblast-like cells which are tall columnar, palisading, vacuolization, all those things. Okay, this is a follicular ameloblastoma. Classically, you have to remember this image. So within these follicles, if I will be able to see these squamous metaplasia, I will call it as acanthomatous ameloblastoma. So what exactly is acanthomatous ameloblastoma? Follicular ameloblastoma with squamous metaplasia is known as acanthomatous ameloblastoma. That is known as acanthomatous ameloblastoma. Now, this is a genetic aspect of ameloblastoma where I want you to concentrate only on the important gene. What is the important gene here? BRAF FV600E. This is the gene which is mutated in case of ameloblastoma. And this was also a question that has previously also appeared in one of the exam. Which is the gene that is mutated in case of ameloblastoma is BRAF V600E. 600E. Okay, so that is about the genetic aspect. Other things, don't worry. Now this is another table showing the oral manifestations of HIV. We know that in HIV, that is human immunodeficiency virus AIDS patients, usually you'll see oral manifestations. So they have classified actually EC clearinghouse. They call it as EC clearinghouse classification. All of us might be aware of this, but we should remember this name, EC clearinghouse. What EC clearinghouse classification tells us is that there is group 1, there is group 2, there is group 3. Group 1 means which are strongly associated with HIV. That means in HIV patients, you are going to see these oral manifestations. What are they? Candidiasis, oral hairy leukoplakia, Kaposi sarcoma, non-Hodgkin's lymphoma, okay, linear gingival erythema. All these are called as five important oral lesions which are strongly associated. All other are less commonly and rare. Forget about these two. They won't ask you. They will ask you only on this group 1. Table 1 is very important. Which are strongly associated. That means these are frequently seen in HIV positive patients. Among that, I'm going to discuss one, that is oral hairy leukoplakia. So this I have taken from the textbook called as Greenspan's Oral Diseases. This image where oral hairy leukoplakia characteristically show white lines along the lateral border of the tongue. So if you check the lateral border of the tongue, you will see white striations. That is oral hairy leukoplakia. Here you can expect also about the histopathology of oral hairy leukoplakia. What exactly you will see? You will see in oral hairy leukoplakia ballooning cells or balloon cells. I want you to remember this term, balloon cells. Where do you see balloon cells? Balloon cells or ballooning cells is a feature of oral hairy leukoplakia. Okay, so the thing which I have highlighted as balloon cells. What are those balloon cells? See, obviously a balloon is swollen. So here the cells are swollen. So swollen cells are nothing but a feature of oral hairy leukoplakia. I want you to understand about certain poisonings here. All of us know lead poisoning. Lead is one of the important heavy metal. If poisoning occurs in a human being, that is called as plumbism. How to identify in the oral cavity? You will see a blue line, bluish black line along the gingival margin, which is known as Burtonian line or Burton's line. Burtonian line or Burton's line is a feature of the plumbism or lead poisoning. Now again, this is another important poisoning, arsenic poisoning. Arsenic also causes very important pigmentation on the skin as well as mucosa, which is called as raindrop. You have to remember this. Raindrop pigmentation is seen in which poisoning? Arsenic poisoning. There are certain syndromes all of us know which are associated with a tooth abnormality. I'm not going to details of this. Some which I'm going to highlight here, that ectodermal dysplasia is associated with anodontia. Typically in ectodermal dysplasia patients, they will have very few teeth. In Down syndrome patients, you will see microdontia, smaller teeth. They'll have smaller teeth in case of Down syndrome patients. They will have hypodontia, less number of teeth. Instead of 32, they'll have very less teeth. Some 15, 16 teeth will be there, and whichever teeth are there, they will be smaller in size. Okay, that is what you have to remember in case of Down syndrome. Now, what about Ehlers-Danlos syndrome? Ehlers-Danlos syndrome is also known as rubber man syndrome. Rubber man syndrome. Why do you call it as a rubber man syndrome? Their skin is so extensible, they can stretch their skin. How in a circus they will show all these features, that is why called the rubber man. They can exhibit some acts, that is why it's called as rubber man. Extensibility of the skin, hypermobility of the joint. We know that temporomandibular joint TMJ is there. We can open the mouth to some extent. These patients, Ehlers-Danlos patients, they can open their mouth very wide. That is called as hypermobility of the TMJ. Now, what about the dental findings? What do you see in the teeth? You basically see enamel hypoplasia. So, Ehlers-Danlos syndrome will show enamel hypoplasia. Okay, so that's the important table which I want you to remember. Coming about the genetic aspect of caries, not much important here. Okay, we will directly go to the serotypes. What about the serotypes here? The Streptococcus mutans, you can see here if you want, these are the genes actually. Here I want you to remember only few important genes which can be asked and which has also appeared as MUC7, mucin 7. That is the gene which helps in oral bacterial clearance. Oral bacterial clearance. That means the oral bacteria clearance. So if this gene is mutated, it causes increased caries incidence. Caries incidence. There is one more gene called as AQPS gene. This is a gene which causes saliva production, increased salivary production. Again, mutation of this gene causes increased caries. So out of this table, I want you to remember these two, MUC7 and AQPS. What are these genes and how are they going to affect the caries? Okay, now all of us know which is the bacteria which causes most commonly the dental caries, Streptococcus mutans. And this Streptococcus mutans has got many serotypes. The most important serotypes here are C, E, F and K. C, E, F and K. Remember which is the most common. I have made the list here according to the incidence. C is the most common one, that is 70 to 80%. E is 20%. F and K are less. So if they ask you which is the most common serotype of Streptococcus mutans seen in the oral cavity is C. Please remember, this can be a classical question and it has previously also appeared in one of the PGI paper. So we should be aware of the various serotypes. Now we have come to the very important topic, that is lip prints, and there is a very important classification given by Tsuchihashi and Suzuki, Japanese scientists, who have classified the lip prints. They have classified lip prints into basically 5 types: type 1, type 1A, type 2, type 3, type 4 and type 5. Please remember these names. Please remember these names. Type 1 is complete straight grooves. Complete straight. That means complete means entire lip they are present. If you can see here, entire lip they are present. Entire lip they are present. Whereas if they are partially present, some part of the lip you will not see the lip prints. They are called as partial straight grooves. Then you have branched grooves, that is type 2. You have intersected grooves, that is type 3. You have reticular grooves. Reticular means they'll form a network. You might get confused. What is branched? What is reticular? Branched means only few. Reticular means it is forming a network, meshwork. Undifferentiated. You can't explain. The lip prints, lip grooves, you can't explain. You call it as type 5. So this classification again can be a potential MCQ. What is the Tsuchihashi and Suzuki's classification of the lip prints? Okay. Now, all of us know Gustafson's method of age estimation here, which is not a criteria. To answer this question, let us see what are the criteria. We know that attrition is a criteria. Yes, Gustafson told that we have to consider attrition. Gustafson told we have to include periodontal disease. Periodontal disease is also known as parodontosis. Parodontosis, also known as periodontal disease, is again a very classical feature of the Gustafson's age estimation method criteria. Then presence of secondary cementum. Secondary cementum increases in case of the age. Root transparency is lost. Dentine, particularly if you see the root, dentine translucency is basically lost. And remember, this is considered to be the most reliable indicator. In Gustafson's age estimation method, loss of dentine root dentine translucency is considered to be the most reliable criteria for Gustafson's age estimation method. So we should be aware of this also. Then cementum deposition or cementum apposition, root resorption, all these are considered to be the classical Gustafson's age estimation method criteria. Now if you come to this question here, we can see that primary dentine is not associated. Remember, it is attrition, yes, parodontosis, that is periodontal disease, and secondary dentine deposition, but not the primary dentine deposition. So primary dentine deposition is not a feature of the Gustafson's age estimation method. Okay, so these are the some of the important salient topics which I have covered here for the today's session. And please go through this video and try to make some important notes from this and try to revise these. I'm expecting at least some questions, 4 or 5 at least, you can say some questions, at least 50 to 60% of the questions from whatever topic we have discussed here, at least 50 to 60% will definitely appear in the examination. So all the best for your upcoming examination and keep studying. Thank you so much.